Welcome everybody to another session of Think Global, the weekly lecture series from the Duke Global Health Institute, where members of the Duke community, both local and global, come together to share their expertise in an informal setting. My name is Kearsley Stewart, and I'm delighted and honored to be your moderator for today's panel, titled Building Ethical Global Partnerships. Today's session is co-sponsored with our friends and colleagues at the Kenan Institute for Ethics here at Duke. So a big thank you to Suzanne Shanahan and her staff for helping to organize today's event. I'd also like to invite you to stop by next Thursday at noon for another Think Global panel discussion titled Health Disparities and the Environment, Who Pays the Price? There'll be 4 speakers from our Duke faculty, led by William Pan, Subrendu Patanayak, Melissa Scott, and Avner Van Gosh. So let me just take a few minutes now to outline today's topic and briefly introduce our speakers. And after that, our format will be that each panelist offers their reflections and comments for about 5 or 8 minutes, and then we'll have a full 20 to 30 minutes for Q&A. Just a reminder to our audience that your audio is muted, but the chat and I believe the Q&A are both open. So please do submit your questions and comments at any time. The wonderful DGHI communications team, headed up by Michael Penn and his team, Mary Brophy Marcus and Aaron Durham, are working behind the scenes today to keep our session functioning. And they'll also manage the chat and the Q&A and help me with those questions so that I can pose them to the panelists in our Q&A section. And I'd also like to thank Michael, Mary, and Aaron for all of their work putting together such a great panel. You may not realize, but it takes hours and hours of organization and coordination to put together an event like today. And so I want to thank them for inviting me into that and for all their work bringing us all together. So our topic today, building ethical global partnerships, is absolutely essential to any success that we hope to achieve in any aspect of global health. Training, practice, research, interventions, governance, they all are built on the foundations of ethical partnership. And without that foundation, without things like trust and transparency and respect and humility and solidarity, we really won't achieve anything of lasting value in global health. But I also want to just take a moment to reflect on ethical partnership is an idea that is framed by ethical theories and frameworks, looking at value and trust and respect. But another key component of ethical partnerships is equity and equality in that collaboration space. And today's speakers all have wonderful and powerful experiences that they're going to share with us about the challenges of achieving equity and equality in an ethical collaboration space. And we're hoping that their reflections on ethical partnership and equitable partnership from ranging from trainees, principal investigators, people working in the humanities and in the health sciences, practitioners and professors, that this broad range of experience, expertise, stakeholders, perspectives will bring hopefully some direction and insight into the challenges that our global health trainees face right now in this very challenging COVID space going forward. And also for the future of global health. I think we all feel like it's really a sort of a transitional and transformational moment, rethinking our partnership, rethinking our collaboration. This is exactly what we should be doing right now. And I'm really, really pleased that we have these experts today to help us think it through. So with that little bit of a background, let me briefly briefly introduce our 5 panelists, and you can go to the Think Global website, learn a little bit more about their professional activities. And of course, link to their professional websites and things like that to learn a lot more about them. So our first speaker today will be my colleague, Professor David Toole, and he jointly holds faculty appointments in global health, the Divinity School, and the Kenan Institute. And he's also an associate dean in the Divinity School for Interdisciplinary Initiatives. David's been conducting research in Eastern Africa for over 2 decades, always with a really special focus on the question, what does it mean to be human? And bringing that back to us in Trent Hall is a really valuable contribution to always grounding us in our global health research and practice, to the value of the humans that are involved in that collaboration space. After David, we'll have Dr. Blendina Mbaga. She's a pediatrician and a lecturer at the Kilimanjaro Christian Medical Center, which is in northern Tanzania. And she's director of the Kilimanjaro Clinical Research Institute. Dr. Mbaga has been collaborating with Duke University for a very long time, particularly with Dr. John Bartlett. And the two of them have set up one of DGHI's most important collaborative sites for global health research and training. So welcome, Dr. Mbaga. Our third speaker will be Laura Mkhumba, who is a native of Dar es Salaam by way of Atlanta, Georgia. And Laura recently graduated from Duke from our Masters of Science in Global Health program. During that time when she was with us for those 2 years as a Masters of Science student, she co-founded the Duke Decolonizing Global Health Student Working Group in 2018. And spun off from that with her colleagues an amazing conference in January, a very important commentary in BMJ Global Health, and continues to forge a leadership path in the space of decolonizing global health. She has over 10 years of research experience in international and domestic HIV/AIDS research, and now she's working at FHI 360 here in Durham on the COVID pandemic. Welcome, Laura. Jesse Ghouler, also a graduate of the DGHI Masters of Science in Global Health program, is now a doctoral candidate at the University of Kansas in the Clinical Child Psychology program, where she's focusing on the effects of mass trauma exposure on refugee health. Today, though, Jessie will be joining us and speaking about her work on her master's thesis research as part of Dr. Lauren Franz's research team in South Africa on autism. And she'll also be co-presenting with her collaborator on that team project. Our next speaker after Jessie, Dr. Nokuthula Shabalala. And Dr. Shabalala is a research officer at the University of Cape Town Center for Autism Research. She's a licensed clinical psychologist with decades of experience in early interventions for children on the autism spectrum. And she's a longtime collaborator of Duke's Dr. Lauren Franz and has trained several Masters of Global Health students. So we're grateful for that contribution. Nokuthula, welcome. So let me welcome all the panelists, and we're going to start with David Toole. And I thought that David could, with his deep and long experience working in Eastern Africa particularly, share some reflections and stories about his work with collaborators in East Africa and attempting and experiencing what it means to try to establish equitable and ethical partnership. So David, let me invite you to share your reflections.
Okay, great. Thanks, Carrie. And welcome everyone, and good to see my colleagues on the panel. Yeah, Carrie and I talked briefly about this, and when I heard that this was going to be a panel on ethical and global partnerships, I had two stories that just immediately came to mind about my own experience in that space. of working from Duke and then working globally. So I'm just going to tell those two stories and hopefully do that in 5 to 8 minutes, no more than 8. So the first encounter I had, and it's not quite 20 years, it's more like I think 11 or 12 at this point, but the first encounter I had was Duke had been given a grant to do health system strengthening somewhere in Africa, where in Africa was not yet decided. So there was a meeting in the Allen Building boardroom, sort of central command for Duke administration, with all of the key players there. And I, at that point, was not a key player as much as a listener. And the discussion at the table was, where in Africa were we going to take this grant money to do health system strengthening? And someone at the table suggested that we go to Malawi because they had relationships there. And immediately someone else at the table said, oh no, we can't go to Malawi. That's where UNC is. UNC has too much research there. So we can't go to Malawi. And I immediately felt in this Allen Building boardroom at Duke as if I was back in Europe in the 1880s and we were dividing up Africa, deciding where all these Duke researchers were going to get to go or not go, depending on which institution was working in what place. So we didn't go to Malawi. Instead, we ended up in Uganda. Arriving in Uganda as an interdisciplinary team at Duke, we were a team of 4 people. I was from the Divinity School. We had a couple people from Global Health, and then we had a person from Fuqua School of Business. And it was pretty clear we did a sort of intensive week-long attempt to find the right on-the-ground partners. It was pretty clear early on in that week that one of the partners we absolutely had to have was the Catholic Medical Bureau. The Catholic Church, via its medical bureau, which is sort of the handmaiden of all Catholic services in the country, depending on how you count, supplies 30 to 50% of health services in the country. And so we met with the executive director of the Catholic Medical Bureau, and he listened to our spiel for about 10 or 15 minutes. And then he told us to please leave his office as quickly as we could, because he was tired of researchers from the global north showing up with grant projects that were already funded that had no input from their side. And beside all that, even if it was a good project, he never saw any of the research. Now that created a problem because there was absolutely no way to do the work we wanted to do in Uganda if we didn't have him with us. So I think, to be honest, I think I was the only person in the room who saw that at the time. And maybe that's because I was the Divinity School and he was Catholic, and somehow I saw a connection. So I worked very hard to get him on board. What happened immediately following is I was told by my colleagues back at Duke that we didn't have time to get him on board, that this was a fast-moving project. We were already behind. We only had 18 months. He was in South Africa in some conference. He wasn't responding to email. And so I pleaded with my colleagues at Duke to say, well, okay, but if we don't get him on board, we're sunk. Long story short, we did eventually get him on board. He became a fantastic collaborator. The grant project ran for 2 years. We got an extension. We tried to get more money from the same foundation to continue it. They didn't want to fund it because they didn't want to risk any more money in Africa. Typical story, I'm afraid. And so it all sort of died a slow death at that point. Although that particular man, who still remains the executive secretary for the Catholic Medical Bureau, became a very good friend. He and I were supposed to appear last semester together at a conference at an American university on the subject of healthcare in Africa. And we built other relationships along the way. So I think it was a good ending to that story, but a fairly disturbing one in the long run in terms of how these kinds of decisions get made on this side in boardrooms in places like the Allen Building. And then, just the learning of the sheer resistance for all the right reasons on the side, in this case of Uganda, saying, we really don't want to work with you because it's always gone poorly. So second story, a few years later, going back and forth a lot to East Africa, I end up in Eastern Congo, where I was at this point working not on a health-related project, but working with the president of a small Christian university. And I was visiting him, and he told me that he wanted to take me to the village that he'd grown up in, Owicha, which interestingly has been the center of the recent Ebola outbreak there. And he wanted to take me to where he grew up. So we drove out to this village. It was about 30 minutes away from where he lived. And he took me to the old mission station where he'd grown up. So this was a mission station that was created by Protestant missionaries in the 1920s. His father was one of the first Christian converts. He then became a pastor of this church, and he pastored the church for 60 years before he died. He was such a popular figure in the region that his tomb is right next to the church. The church building itself still is operable and in good shape. Right next to the church on the other side from the tomb, however, was the house that this guy grew up in as a little boy. And we're standing in front on the sort of dirt road in front of the church, and there's the tomb, the church, and then this little dilapidated brick house. And he says, that's the house I grew up in. And then right behind us, he said, now let's turn around. And we turn around and look right behind us, and that was the original mission station. So this is where the missionaries lived. In this case, the brick houses were in decent shape. There were people living in them. And it was sort of a beautiful serenic scene of orchards and nice grounds. And he said, well, that's where the missionaries lived. And he said, as a little boy, I used to look across the road to their houses, and I used to wonder why they had lights on at night and we didn't. And the answer was they had generators, and his father didn't have any generator. And he said, and also we were hungry all the time. And he said, and they had fantastic fruit trees. So we used to run across the road, sneak into the orchards and try to steal the fruit. The problem was they had these really mean dogs, and they would sick the dogs on us. And so I'm just absorbing all this and listening to this. And then he turns to me and he says, you know, I'm really glad that the missionaries came, because if they hadn't come, my father wouldn't have converted. He wouldn't have been the pastor of this church for 60 years. He wouldn't be buried right there. This community would not be what it is. And I myself wouldn't be Christian, and I wouldn't have started this university. None of this would have happened. I'm so glad the missionaries came. But you know what? They were sons of bitches. Now, I'm paraphrasing slightly because he's a deeply Christian man who wouldn't swear, but without using those words, he wanted me to know that the missionaries, he was very grateful, and they were sons of bitches. And then, without saying it again in quite such blatant terms, he looked at me and said, and you know what? I'm so glad that you are here, but you're a son of a bitch too. And I think that's the end of my time, end of my stories. For me, those two stories have been probably the best short description of what all my work in East Africa has been like. Very hospitable people who are really honestly glad that I'm there, but always wanting to remind me that I'm there with a certain kind of history and a certain kind of baggage, and that I should never forget that. So that's my piece for now.
Thanks, David. And I think that that's such a powerful example of what transgenerational trauma could mean for that's underlying some of the perhaps when our young trainees go and start to build relationships, and they don't have a sense of why they're not being welcomed with open arms. This is a really important example of sort of transgenerational trauma that has deep roots in the colonial moment that are still resonating with us today. And that's the importance. That's one of the things that the Decolonizing Global Health Group brought to our attention at DGHI, the importance of starting their training with training in colonial history and an understanding of that relationship. And so we thought that we would now transition to Dr. Blandina Mbaga, who could sort of reflect on David's stories and reflect on her own experience collaborating in the past few decades, but also having obviously grown up in Tanzania and having an awareness of the colonial moment. Dr. Mbaga, do you want to, share some thoughts and reflections with us on what it's meant to you, that colonial history, and trying to start and build ethical and collaborative partnerships, research partnerships, as well as clinical research partnerships in your work in Northern Tanzania?
Yeah, thank you very much. And I'm happy to share the experience. Yeah, with my experience of working in research activities, as well as in collaboration with other institutions in and outside the country, I can share that doing research outside your country, especially for people who are coming in Western country to the African country, is quite important to be familiar with the cultural and society within the areas where they're going to interact and work with. And for that means it's quite very important, even if the project or activities are planned to be done in a country somewhere in Africa, to discuss from the beginning and share the stories and understanding, and so that even if something is produced, people can be able to implement that within the entire area where it is intended. Yeah, sometimes it might be difficult, especially before. Nowadays, it's quite good that we share, we discuss from the beginning, we put in idea. If we agree to do that or we don't agree to do that, then we can change to really feel that is cultural adapted in our areas. But in that before, which we say that now we are decolonizing, people were coming with ideas, with research already funded, and just coming like we are coming with money and doing the research. And for that cut, they don't have a real feeling sometimes with what is really needed within that environment. As a challenge, they face challenge into implementation, because you have to know that in order to implement, we have very many different stages to go through, from the community maybe to the top leadership, and different authorities needed to approve, needed to understand, and in the community, people needed to be involved from the beginning. Unfortunately, what happened before, people were just going, informed and maybe paid, and informed that will come back maybe to pay you, or will come back to bring you the results from what we have done, and they disappear, not coming back. And this make people live in pain, so that other people, whenever they come, they're like, no, we don't want you to come into our environment because you are lying, you are just using us. So I think it's quite ethically to make sure that the research is equitable and shared the benefits from both societies where it's going to be done, and this giving feedback, making you welcomed next time whenever you come, and people are happy to contribute, to work with you, and to do the activities together. And if something is not possible to be done, there's no need of like promising giving a big promise and lying, making people being in quite a kind of need. So for those who have not yet worked in Africa, sometimes they're asking themselves how to go through and how to enter in. Most important thing is to have link a person and discuss the idea from the beginning, share, and especially understanding the ethical and regulatory issues within the entire community and country, and be ready to accept and adhere so that things can move. A good example is like, I'm working with very different collaborations, and I have been struggling most of the time in making people understanding how things are working within our environment, especially from developing the activities, what can be acceptable and what cannot be acceptable, applying for ethics. Before we go for ethical application, we need to have some regulatory authority approval that they are ready to handle the research and they take over, supporting us implementing before we go to start submitting for ethical approval. And when you go for ethical approval, we know that they will take some time, and there are some questions which will come back with foreseeing and maybe put into that at the beginning. And that is quite very important. So the most important thing I can say and advise others is making sure that you are working together, and if something is not understandable, keep on asking to learn, so that even if you are going to do the research in that environment, you are quite knowing the environment and you are getting enough information so that you can be able to implement the activities in that area. And one of the things to think, what I say, it's good to think about having benefits on both sides. It's thinking of capacity building so that you can be able to continue building up your activities because you have already trained people, you have people trusted who you can live in the place. And trust is quite very, very important, because if people feel that you don't trust them and you really want to feel that things can be done only while you are in that place, then they can put back their hands and just looking at you, and things will not move at all. So trust is quite very important and transparent to support the activities moving and be well implemented. When we talk about capacity building, need to think about bi-directional capacity building on the side of the collaborators, on the other part as well, the side of the collaborators where the project activities is going to be implemented, to make sure that you build the people who in the future you will be able now to keep on working together, even applying the grants together with them as part of now the co-PI or MPI, but to have brought them from down and up. In my experience, I can say that I have enjoyed very much the collaboration which I have been having with the DGHI, because I have been brought from down from 2006 when I first trained in research methodology at Duke. And I've seen the way I'm climbing up, and that is the way I'm trying to build a lot of chain of my young career to develop them up by taking the same example. That means I got a good example, which I want others to go through and also enjoy the benefits of research. And whenever you do research, they feel like they want also to do and be into that field. And in building a good partnership and capacity, I can learn from the example of John Bartlett, the great work he has done in Tanzania by building capacity in training mentorship from the first phase of undergraduate, then the phase of MEP junior faculty. First phase, it was on the KSMC. Second phase, extended to another institution, which is KUHAS. And the third phase now with HAPPY, extended to the third institution, which is Muhimbili. So this has made ourselves internally also be close and work together and enjoying the product of research. And we can see people inspire linking with the collaborators so that they can do and implement their activities. Yeah.
Thank you, Blandina.
Yeah.
Could we hold the challenges for the Q&A?
Yeah.
Great. Because okay. I think like this is a wonderful moment to transition, Blandina, from your description of the arc of your career as a young researcher to now as a principal investigator, as someone who's in an administrator and supervisory role of many clinical trials. To switch now to Laura, who is beginning her research career, having done research herself, but finishing her training and going out. And I can't help but be struck by many of the comments that you raised, Dr. Blandina, about how to establish equitable and ethical partnerships are still questions that we're wrestling with now, and that Laura and Jesse and their colleagues are confronting now. So there's a nice parallel between the arc of what you've been able to do, but also with what Jesse and Laura are about to step out into in their careers. And I'd like to invite Laura to offer some reflections on that, thinking about Blandina's career, and now you're starting your own. And just a tiny reminder to our audience, you're most welcome to submit questions to the chat and the Q&A. We'd really like to incorporate some of your comments when we get to the Q&A in a few minutes. Laura.
Yes, thank you. Definitely as a reflection that I have, especially with a colonial lens, is just thinking of how oftentimes in our field, in global health or in research, we often, as David and as Bundina have mentioned, will ignore the historical context of the communities that we're going into. And that was one thing that was very strong for me going, and and as we mentioned, I was born in Dar es Salaam. I grew up in Dar es Salaam, Tanzania, and I moved to the United States. And I did my research in Tanzania. I went and did my field work in Tanzania. And when I went in, initially when I was going in, I had this naivety of thinking that, yes, I am going back into my community. Yes, I am going back to my home country. However, there had to be moments where I had to take a step back and really reflect on the privilege and the spaces that I'm going to occupy as now a Tanzanian American who is now receiving training in the West. And one of those was doing that critical reflection of how did a lot of our global health institutions come to be? How did the field of global health come to be? And how did the way that we conduct research come to be? And those were very difficult internal reflections to have. And that's because a lot of it is confronting that everything that we do, unfortunately, no matter our best intentions, is rooted in white supremacy and colonialism and racism. And as a result, we can try our best intentions. However, there will always be some harm that is done. And one way that we, with my co-founders and my fellow members of the working group, was we obviously, as trainees, there was only so much power that we had, but we really pushed, especially with our fellow classmates, is really thinking, knowing that the systems that are in place are these big and have been in place for centuries and are so entrenched in everything that we do, how can we as trainees, where now many of us are going to go to other countries where we are not from there, where we may not know the culture, and oftentimes may not know the historical context of where we're going into, what are some of the things that we can do to minimize the harm that we will do in these communities? And again, with thinking of ethical partnerships, one thing for me is having that really critical personal reflection of the space that you occupy in your home institution. So I had to think about the space that I occupy here in the United States as a Black woman, and then think of the space that I will occupy both as a Tanzanian, but then also a Tanzanian who has lived in the US and has the privilege of then leaving at the end of 10 weeks. And thinking of how will the work that I do then actually be meaningful, and how, as Bunny mentioned, that capacity building. Am I only contributing to the system where we are dropping in trainees or dropping in researchers for a few years and then they leave? Or are we building a system where there's actual partnership and we're actually considering this is a collaboration, but also it's not reliant on people from Western institutions coming in every few years? But then also thinking of the reason that I am able to come from Duke and go to Tanzania is because there is a history of colonialism that has left a lot of these countries that we're going into, but these communities that we're going into, with poor health outcomes, and disenfranchised and marginalized. It's not happening in a vacuum. It's not something that just happened naturally. There is a very strong history there of oppression. And again, white supremacy, slavery, and colonialism. And so thinking of, again, how can I make sure that as a trainee and now as an early career researcher, and hopefully be a scientist in the future, what are ways that I can stop perpetuating those legacies of colonialism and those systems of oppression that unfortunately do underpin the field that I work in? So one of those is that doing that personal reflection. And just to echo what Dr. Mbaga mentioned is, one big thing is, before, there's usually a lot of work and research where we do stakeholder engagement during, but I've noticed not a lot of work pre. So before writing the grants, before writing the protocol, the proposal, talking to the communities that you're interested in, being very intentional about engaging them and asking, what exactly do you need? I don't want to just write a proposal as a master's student. This is what I'm going to do. And I have not engaged with the community that I'm going to work in. And so that is another thing that we've really been pushing, especially with trainees, and encouraging, pushing us with a lot of programs, is teaching and encouraging, in the trainings that we do, is teaching students to really think about, how can we start before we implement this project, before we write this proposal, what are the ways that we engage with the communities that we're working in, but then also having that personal reflection of the space you're going to occupy once you're in the field and once you're doing that research. So I'll just stop there and answer more during the Q&A.
Thanks, Laura. And you very powerfully sort of collected all of the stories and the experiences of both David and Dr. Blandina, and reflected on them as a student with a really unique perspective, both as someone from the continent and someone trained in the US. And it's a wonderful transition to our next two speakers. And I'm just going to take a moment and look down here and see if I can share my slides. The issues that you raised, Laura, are something that I think are a daily and very openly engaged with in South Africa, for sure. And so we're really lucky to have, as our two final panelists, Nokuthula Shabalala and Jesse Ghouler, that are going to reflect on race, as well as many other things, in their research collaboration on autism in South Africa. So can everybody see my slides? I'm hoping that that's okay. I got a thumbs up. And Nokuthula, can I ask you to start? And shall I just move to the next slide for you and Jesse? Oh, sorry, Nokuthula, could you unmute yourself? Let's see. Oh, we're still waiting, Nokuthula, to unmute. Is that something that we can do on our end, you guys? Still can't hear you.
Can you hear me?
There you go. Now we can hear
Okay.
you. Great.
Okay, thanks. Something's happened here. I'm not sure what.
No worries. And Jesse, why don't you unmute too, since you guys are presenting together?
Sure.
Should I go to the next slide or remain on this slide?
Yeah, no, just on the second slide.
Okay. All
so
right.
thank you for inviting us to share a bit about the work that's happening through the partnership between your institution and the UC team. And the partnership started when my colleague Nolene and I met an ex-South African, Dr. Lauren France, and our shared interest in developing an intervention for young South African children with autism made for a natural fit. So the visual in the second slide summarizes our project well. And at the top, you see is the intervention specialist, and at the bottom, the ultimate beneficiary, that is the child with autism. So in order to bridge the gap between this, the gap between the two, the intervention specialist and the three clinicians that are trained in the intervention in turn train and supervise non-specialist early childhood workers to coach and support parents. And we talk about them as non-specialists because they don't have teaching diplomas or qualifications per se, nor do they have expertise in autism, but they are employed by the schools. And so they are positioned well to work with children. So in this partnership, there have been challenges that I'll talk about briefly. So the key one, I think, for me was that in adapting this intervention, this first world intervention, it was critical that we don't water it down, kind of dumb it down in order to deliver it to socioeconomically deprived and vulnerable communities. So we needed to ensure that the research and clinical rigor, as well as conceptual integrity of this model, remain, and that we adapt and implement something that is solid and not just watered down. And the second of the challenges, I think, in addition to just wondering about or overcoming our differences and disagreements, maybe about should the strongest focus be on the research component or clinical, and it was just kind of working through those challenges and differences in opinion. We needed to remain open and reflexive as a team. We are South Africans, and we have a history around race, class, and gender and sexuality and stuff. And we needed to remain reflexive and thoughtful, both in respect to one another, to the team members, but also to the people that we work with. Because issues of race, for example, they emerged, and they kind of emerge from time to time. But because we are able to call each other out on things and to talk issues through. So I'm thinking in relation to research participants, we needed to be flexible. And what comes to mind is a session, a focus group discussion that I co-facilitated with Jesse, where it soon became clear that the participants needed to talk to one another about more than our research questions. And so understanding that these parents of kids with autism have managed a lot without support from others in their environment, we actually needed to make the space for them to talk about issues. But what that meant is that what was meant to take an hour and a half was a 3-hour-long session, and we were finished by then. But what was also interesting is that the participants, who were all people of color, in South Africa we have like black and colored, and that, but it was people of color. They spent most of their time, if they were talking to us, they were directing everything to Jesse and sort of ignoring me, but that's not unusual given everything in South Africa. So Jesse, will you talk about that last issue?
Yeah, so another thing that we really noticed with challenges was just thinking through how to integrate trainees into this collaborative context. And I was the first Duke master's student that went over to Cape Town to work with the team in 2015. And so definitely thinking through a lot of like the preparation of students, but also the training of students in the field. And one takeaway that we all frequently talked about during and after was just this idea of trainees really focusing on giving and listening. And I think Laura said it great too, just a lot of self-reflection and being really acknowledgeable of your privilege and your background, and really doing a lot more giving and listening than taking and talking. And I definitely think that was something that was really impactful for me when I was in Cape Town.
Could I ask a question of you both, Nkhumba and Jesse, bringing in this really powerful moment, which I'm sure many of us have also experienced, where the local leaders. So in this case, Nkhumba, you were the senior researcher and the interventionist, and Jesse was the trainee, and yet the research participants or the clinical attendees were looking to Jesse rather than to you. How do you overcome that? How were you able to overcome that? Can you see do you have any ideas about how to position the both of you before you enter into that space with researchers so that maybe that doesn't come up as easily?
I don't know if I have any answers to that, but in some ways, I think for me, it was not unexpected. It was not unusual. I think for most people of color and so on, but also then having to balance what you want to get out of the research and whether to address things. I think one of the things for me, and I'm talking purely in my personal capacity, I often feel like I need to choose my battles carefully.
Mm.
And in that room, I had more power, regardless of everything else. I had more power than the participants, and it was not. It would not have been a good call to engage in that, I think.
Mm. So the reflection here is that these power differentials, these racial inequities and hierarchies are always there, but maybe the message for our trainees is to understand when the right moment is to engage with that directly for the best effect.
Yeah.
I know, Toole and Jesse, when we were talking yesterday, you also talked about racial challenges within the team itself. So you're all more or less sort of peers, although obviously some people have more training than others. But if you could just talk a little bit about that some of those experiences of racial hierarchies within the team, the professional team itself.
Yeah. Look, it's difficult. We have a history in South Africa, so to think that any of us would come out of that unscathed and untouched, I think would be kind of naive. And the moments do come, but I think we have a very strong partnership and relationship as a team or as a partnership. We have strong enough relationships that we are able to call each other out and to talk things through in ways that don't do more damage and stuff. I mean, I often talk to Nolene, who is a colleague that I've worked with and a friend. And sometimes she'll say something and I'll be like, oh, that's so white. And so we have a code, we talk, we're able to do that. I'm able to say that to her and she's able to call me out on things as well. You know, when I sort of, I think, dominate and I don't know what the word is, almost like not making the other person feel heard or something. But the point of it is we have a good relationship, working relationship. We see one another outside of work as well. And we have a kind of a practice of celebrating little achievements and successes. We also, prior to COVID, we took turns providing meals for the team in our Monday meetings. And what that also did was to sort of help us get a sense of into each other. So I'd make them some African food and somebody else made this. Marissa makes very nice Afrikaner food and things like that, which is a way of getting into the other person's world and culture. And I think that awareness and reflexivity is key in this thing. Just knowing who you are and your position and what that means and the power that comes with who you are.
Hmm. Hmm. Jesse, did you want to add on to that? Being in that amazing space, being facilitated in that way?
Yeah, I mean, it was definitely a very amazing experience. And I think really as a trainee, there's so much going on. You're like exposed to so many new things. So I think it's kind of that openness and self-reflection of being open to lots of teachable moments and just all of the ways you can learn. And I think for me, that happened before, during, and after being in Cape Town, and it still happens to this day, 5 years later. So I think just really having that openness and awareness to be taught and to learn. And it was definitely the way Noctula describes it was the way it was experienced, and it was a really, really great training opportunity. And also just thinking about what that means for the bigger picture and what the mission is of this project that is so important that they're all working on.
Hmm. And I'd like to invite the other panelists to jump in here. We're sort of moving into the Q&A section and invite all of our audience members to submit questions as well. So thinking about Noctula's leadership role there in South Africa with Jesse, I'm wondering, Blandina and or Laura, since both of you were in Tanzania, different setting, but these challenges of navigating power differentials, maybe not racial, but certainly power and class differentials in the Tanzania space for you, Dr. Blandina and Laura. If you had any reflections on that, building off of what Noctula and Jesse have shared with us. Love to hear your reflections now or later. And David, if you had anything as well. Great. I'm gonna just stop sharing my slides right now so that we can get to the full, I think we can hopefully see everyone now. But these issues, you know, I think are very challenging, and perhaps South Africa is, it's something that's on a daily, people are experiencing and engaging with those issues daily, where that might not be the case, obviously, in Tanzania. But do we have any, does anyone, before we turn to some of the other questions, is there anyone on the panel or in our audience who wants to talk about or raise any issues related to race in the global health space, either here in the US or in their training sites?
I can talk a little bit more or just give a reflection of that.
Great.
And say that, you know, even working as a Tanzanian American and working in Tanzania, I have also had those encounters. Actually, just a quick story of when I was an undergrad and did my fieldwork also in Tanzania, I went on a team with two other, they were white women. And when we would volunteer in the clinic, a lot of the patients would actually look to not me obviously, but to my fellow colleagues who, by the way, we were in undergrad, we are not medically trained, and we were just pre-med, but would ask us to confirm whatever the nurse or the doctor was saying. And that was just something that came up, which again links back to understanding the historical context. And it really, for me, just made me, in that moment, obviously I did speak up and say, you know, no, we are not doctors. We are, you know, it would be unethical of us to do anything beyond just observing and shadowing in this moment. But also thinking of, again, the historical context of, this is a community that has seen for decades white people and missionaries and doctors coming in, and they were usually the ones that are put in this pedestal as the healthcare providers. And when we also view, again, going back to those oppressive systems that do tout Western knowledge as superior to what the knowledge would be in Tanzania or the traditional knowledge, wasn't surprising to me to encounter that. It was something that, not that I was prepared for it, but I understood it in that moment. Again, taking a step back and reflecting of, well, historically, this is who they would have expected to be the one to give the information. And there probably was an instance in the past where they were either told or it was demonstrated for them that in a team of Black and white colleagues, the white person is the one who has the better knowledge and is the one to confirm everything. so for me, it was not putting the onus on, and really I wasn't upset with the patient because I understood again that history of like why they would have thought that and why they would have asked and referred to my white colleagues' opinions over really the doctor and the nurse who actually were medically trained. And just really thinking of, again, as I was furthering my training in global health and in research, how can I and how can I work with my classmates? How can we really do better so that the students that come after us are not constantly having to deal with that and are, not being confronted with these issues where, again, they're very much rooted in history and oppressive practices.
Mm. Thanks, Laura. David, did you have something you wanted to share, or if not, what I wanted to do is just take this moment to move the conversation, which has been about interpersonal challenges.
Hey,
Yeah, go ahead.
I was speaking, but I forgot to unmute.
Okay.
I
Okay,
have
great.
I have a couple quick things I could say on race that are sort of in story form again. Like, so one of my closest colleagues in Uganda was actually someone who at the time taught at the Divinity School at Duke, and now is at Notre Dame. And in many ways, he's the guy who introduced me to Uganda once I was there. And he wrote a great essay years ago when he first came to the U.S. To live and teach. That he opened up by saying that I didn't know I was Black until I moved to the United States. And it was a really interesting, something that I've heard from other Africans. I don't know if that's been, Laura, your experience, but the sense in which, I mean, honestly, as a Ugandan, where almost everyone's Black, Black's not a color that gets racialized, but if you're a Black person from Africa and you move to the US, you have to learn what it means to be Black. And at first he resisted it, right? Because that's not how he grew up, until he lived in North Carolina as a Black man and then realized that, oh, I'm Black, and experienced all the negativities that go with that. And in an odd and interesting way for me, as a white person going to Africa, particularly to Uganda and working in rural Uganda, where indeed you are the only white person there. In some ways, I had to go to Africa to learn that I was white. I mean, I remember walking at night with some Africans one night along the road, and there was a boda approaching with headlights, of course, and they said, "Oh, look, you glow in the dark." And their sense that my whiteness showed up for me in a way that it doesn't show up here. Of course, then my African American friends here remind me that, yeah, so that feeling that you had when you were the only white person among a bunch of Black people in Africa, and how you stood out, and then you like got to leave and come home, like that's how we live every day, right? So those, that kind of knowledge, it's a subtle thing. Well, one last thing. I was just telling my wife this story last night, because I don't know even how it came up, but also being out in African villages where, a mother will bring you their baby because you're a novelty, and then the baby does nothing but scream because you scare the hell out of them because they've never seen anything like you. And these are small adjustments to consciousness, I think, as a white person showing up in Africa that you need to take to heart, and then also bring home here, recognizing how things flip when you get back to this culture.
Thank you, David. And I know we just have 2 minutes left, and what I wanted to do in the last 2 minutes was and we have some wonderful questions as well, which we won't be able to get to, but these reflections that we've just had are about interpersonal race relations in the context of doing research, whether we're white researchers finding ourselves in Africa, or Black Africans, as well as white Africans in the case of South Africa, working with white American or Black American students. These are interpersonal issues, but they're also shaped and determined by structural issues. And just in the last minute that we have here, Blandina and I chatted yesterday about the structural, how these inequities are embedded and perpetuated by the structural inequities and unfairness of NIH funding. So Blandina, just in the last minute that we have, I also just want to bring in some structural examples of how these inequities shape and determine everything that we do as global health researchers. Could you just comment a little bit, Blandina, on the unequal indirect costs as an example of how these big structural features shape what we can and can't do to achieve equitable and ethical global partnerships?
Yeah, thank you very much. Yes, actually being working with so many collaborators and different researchers, I've seen the difference with NIH fundings, where for years we are working with indirect costs of 8% for the country outside the US, but I've been seeing the US institutions, the indirect cost being changing from those years we had maybe from 50, now maybe to 60, in other institution maybe to 70. But in our institution, even requesting to hold minimum institution request for 10%, you find that it's not allowed and is not negotiable with NIH. So for me, this, I see that is not equal. And for our institution will never grow because depending on 8%, the institution growing, building capacity and growing will always depending on support, even to support internal people in building capacity. If they are not attaching in any project, it becomes a huge challenge. A good example, like we have seen, our institution was closed because of lack of capacity of lecturers and whatever. But this is because even if we're engaging a lot with so many collaborators, what we are getting, you cannot even sponsor some people to go and study because of the very small indirect costs. We have been arguing with like institutions in Europe, they have gone to 25% standardized within the Europe and within the Africa, in UK it's 20%, in Denmark to 20%, and they standardize both. But I don't see why it is a challenge for the NIH to think, even raise 10 to 15% so that they can support it. Even internally, the institution, they can build the capacity. So
thank you, Blandina. And so I think with that final reflection, everyone should take away that achieving ethical and equitable global partnerships is both a personal and an interpersonal challenge and a journey, as well as working in this global health space. We have limitations such as Blandina just shared with us. And the US is behind on that. We can see, as Blandina said, that our European partners are ahead. So let me offer a very heartfelt thanks to all of our partners and panelists. They've devoted a lot of time to prepare for this, and our participants, our attendees. Thank everyone, DGHI communications team, and wishing everyone good health. And I hope that we can continue this conversation actually again. So thanks from DGHI. Bye.
Thank you.